Hi, I'm Dr. Salil Khandwala, the Medical Director at Advanced Urogynecology of Michigan. When you were here the first time, we talked about the initial workup and information about what is pelvic organ prolapse. Let us now talk about the management of pelvic organ prolapse. So first of all, let us do a little recap of the pelvic anatomy and the muscles. So as you can see in this particular slide, this is the bony pelvis, and inside the pelvis is the pelvic cavity, which is filled by the pelvic musculature. And these pelvic muscles essentially control the passage of the urethra in the front, the vagina in the middle, and the rectum at the back. The ligaments that reside on top of those pelvic muscles also help with control and support of the pelvic organs and prevent prolapse. So this is the normal deployment of the pelvic organs in a woman. As you can see from front to back, this is the urinary bladder, which holds the urine. The urethra is the tube that brings the urine to the outside. The vagina is behind this, uterus on the top, and the rectum at the back. So from front to back, you have the bladder, the uterus, and the rectum. Now, typically, if I were to show in this diagrammatic representation, this would be the boat, which is the uterus or the vagina, which is afloat because of a tonically or a constantly contracted pelvic floor muscles. The boat is supported by the moorings or the ligaments, and these ligaments essentially for the uterus hold the uterus in place, but the main support is coming from the pelvic muscles. So if the muscle were to weaken, in other words, the water were to dry up, then there'll be more strain on the moorings or the ligaments. Now, the more the water dries up and the more the muscles weaken, therefore, the ligaments are put under greater stress to the point that they'll eventually break, and then there is prolapse. So this is a very simple analogy of how uterine or uterovaginal prolapse happens. So for this, you need the efforts of both the muscles and the ligaments, without which you will have weakness of the tissue supports and therefore onset of prolapse. So here you have the muscle weakening, at the same time the ligaments breaking, and then things start herniating out of the orifices. So what causes prolapse? As we talked about last time, there are several factors. A few prominent factors are childbirth, straining activities such as coughing, lifting, constipation, sometimes coughing, which is also associated with smoking, and smoking also weakens the pelvic floor tissues. Then you've got obesity, menopause, and the overall connective tissue that the patient inherited from her parents. So what is the genetic predisposition to having prolapse is also as important. So we talked about the different types of prolapse. Cystocele, which is also called the front vaginal wall prolapse. So this is the front. You have the front and the back as we described. The bladder is here. As the bladder starts falling down, you start getting the cystocele, and when it comes outside, then it becomes more prominent. The uterine prolapse is a large cystocele where the bladder is significantly coming outside and almost has essentially fallen out of the vaginal opening. Then you have uterine prolapse where the uterus starts herniating downwards, and as you can see, it's coming down to halfway to the opening, and then it's coming outside the vaginal opening. And this is a classic case of complete uterine prolapse. Then you have a rectocele, which is the back vaginal wall prolapse, where you can see the rectum is bulging forward, and it's bulging even more forward and causing the rectocele. Anorocele, also called the small bowel hernia, is usually seen after a hysterectomy. As you can see here, there is no uterus, the vagina is closed, and the small bowel loops reside on top, as you can see here. And when the vagina starts falling down, the bowel loops come through at the top of the vagina, and they are part of this bulge, and the small bowel hernia is then called an anorocele. As you can see here, this is a back wall prolapse, which is a combination of both rectocele at the lower part and the anorocele at the upper part. So the typical symptoms of prolapse is a bulge. So remember, many patients come with different complaints, but one complaint which is always consistent is that I can feel a bulge coming outside the vaginal opening, especially when I'm on my feet or doing activities, and they notice this, which is a classic manifestation of prolapse. Then there are other complaints based upon which wall of the vagina is falling down. So if it's the front wall, but the bladder is coming down, then there are issues such as difficulty emptying the bladder, urgency, frequency, especially nighttime frequency, retention, bladder infections, urine leakage, especially with urgency, and what is called hidden or occult stress incontinence. So let's review some of these symptoms. So what happens with a vaginal bulge? As you can see, when the bladder is coming down, look at this urethra. Normally, the urethra is a straight tube to the outside, so it's easy for the urine to come out. However, as the vagina starts falling back and the bladder starts falling into that prolapse and causes the cystocele, you can see that the urethra, which is the tube, is getting bent. And because it gets bent, then it becomes very difficult for the patient to empty her bladder. And then what you have is a retention. From the rectal prolapse symptoms, it's difficulty in emptying the bowels. For example, here, the stools are trying to come out. They ideally are supposed to come out from this opening to the outside. But if there is a large rectocele, then the stools will go in the front and sort of get hung up in this cul-de-sac. There's nowhere to go. So because they get hung up, the more the patient strains, the worse becomes the constipation until she almost splints the vagina so that the stools can come out through the right opening. Also, because of the stools collecting there is more gas formation and there is easy leakage of gas and also liquid stools and obviously constipation. So prolapse by itself can cause complications, right from the bladder complications to the vaginal complications to the bowel complications. So let's see what complications these could be. This is a long-standing prolapse that causes vaginal ulcerations. And though this doesn't look that great, but you know what? It's quite common, and we see it very frequently in patients who have had prolapse coming out of the vagina and has been ignored. Now, why does that happen? Because of the friction against the legs, the drying of the tissue, and the venous congestion that results in breakdown of the tissue and bleeding. The other thing that we see is retention. As you can see, this is an MRI picture of the bladder, which is completely distended in a patient with prolapse. And that can cause bladder infections because now you have stagnant urine. It can cause repeated bladder infections, could eventually lead to kidney infections. Kidney infections lead to kidney damage, and kidney infection can also lead to septicemia and possibly septic shock. So it is very important that these bladder infections not be ignored, and especially if there is a cause such as stagnant urine that needs to be dealt with. So as you can see that a large cystocele will cause that urethral kinking, and that kinking itself can cause the bladder from not emptying and cause a retention. The other big problem that can happen with especially a large prolapse is ureteral kinking. So the ureters are tubes that drain the kidneys. So these are the two kidneys, one on each side. The kidneys filter the blood and make the urine, which is transported by these two tubes into the bladder, and the bladder eventually stores it until it's time to release it. However, with prolapse, as the bladder falls down, the ureter also may fall down and it can get kinked. So it depends upon how much it falls. So the greater the degree of prolapse, the greater is the degree of the obstruction. Now the ureter cannot empty. It causes back pressure where you have a distended ureter, not a thin normal ureter, and you have a distended kidney. Eventually, you can see this cortex, the normal tissue of the kidney, gets thinned out and destroyed. And this could cause kidney damage. So the problem with a long-standing vaginal bulge, especially a large cystocele or even a large uterine prolapse, could be that the ureters can get kinked, and that is really not good because the longer they stay kinked, there's a greater chance of kidney damage, And once kidney damage is done, it's over. The kidneys can atrophy and they stop functioning completely and have to be removed. So that's the worst thing that we can have happen with prolapse. So we want to really make sure that if the prolapse is coming out, you must get it taken care of. Do not ignore a prolapse that is coming outside the vaginal opening and it is causing especially some of these problems that you may not even realize that they're happening. So remember, complications because of prolapse are not uncommon. And remember, some of these are insidious. That means they're hidden. You may not even realize it's happening and they're happening. Unmanaged prolapse, therefore, means if you ignore it, has more danger than the complications of treatment. So leaving it unattended has greater risks and danger than taking care of it. So let's not wait. Let's get this managed. Last time we did an examination, and in the examination we went over lying down examination, then legs bent up, and also standing up examination. And we also did the prolapse workup where we assessed the bladder's ability to empty. We probably did the voiding diaries. You have or will be completing the urodynamic testing. So this is the voiding diary that you may have completed by now. And that's really important because it'll show us the difference between day and nighttime urine volumes, especially when the prolapse is coming out and it's a bladder prolapse. Now, why does that happen? I mean, if you think about it, the more you are on your feet and standing up, the prolapse is getting worse. So the ureter and the urethra mainly is getting kinked and the bladder is getting backed up. So with urethral kinking, the bladder cannot empty, and that results in these small voids, frequent urination, especially because you feel that you're not emptying your bladder completely. Then when you lay down at night, the prolapse gets naturally reduced because the gravity is no more. And when it goes inside, then you're able to empty your bladder better and you're going more frequently to the bathroom at night. So what we also see is that at nighttime, patients are actually urinating not just more frequently, but even more amounts than what they would do in the daytime. The urodynamic testing will help us understand as to how well you're emptying your bladder and also assess for occult urinary incontinence. And I'll talk about that in a second. The other thing that we look at is if the patient has urinary retention. In other words, she's not able to empty and she has a large prolapse. Now, is it exclusively because of the prolapse that she has retention, or can there be some other cause of it? And that is what this test will help us understand. Does the bladder muscle contract and actually empty if the prolapse is reduced, or is the muscle itself not working? Now, why is that important? Because let's say a woman has retention, that means she's not emptying and she's holding back urine and she has a bulge. Now we repair the bulge. It may be that if the problem is with the bladder function itself, then the problem may still continue and she may still have retention. So it is very important to understand this before we do the procedure, so then we know what our expectations are. Also, if she has hidden leakage, then I may not do a sling in a patient who has ongoing retention, and we may do the sling later on. So these are the different assessments that we do to make sure that not only is the bladder emptying well, but does she have this hidden leakage. So what is meant by hidden leakage or occult urinary incontinence? Most patients who have a prolapse will in fact state that when the prolapse was mild, she was having urine leakage with laughing, coughing, or sneezing. The moment the prolapse got worse, the leakage actually got better. And why does that happen? So as you can see in this particular slide, as the bladder comes down, remember we talked about that urethral kinking. So when the more she strains and coughs, the bulge comes down more, and when it comes down more, it kinks the urethra, and therefore she's unlikely to leak. Now that's hidden because this kink is artificial, and that's because of the prolapse. Now guess what? We have corrected the prolapse now. The vagina is back where it belongs. The bladder is where it should be. Now if she coughs, and if there was weakness of the urethra, Because the kink is no more as the prolapse has been corrected, guess what will happen? She will start leaking urine. And that is what we want to avoid. And that is why we check for hidden or occult incontinence during urodynamics. We do not want urine leakage to happen. The other test, as I mentioned, is to look inside the bladder with a telescope, which is done completely under local anesthesia with minimal to no discomfort. But the major reason for doing that is to assess in patients with retention, those who have frequent bladder infections, especially patients with urgency and who have blood in the urine or have a family history of bladder cancer or smoking. Those were the bladder tests that we do. Now the bowel function test is to assess if a patient especially has constipation or gas leakage, then we do stool diaries and do a couple of tests called anorectal manometry and anal ultrasound. So this, just to give an idea, this is an ultrasound of the rectal sphincter. So this black halo that you see here, that is the inside sphincter called the internal sphincter, which here is intact. And the white halo around it is the external sphincter or the outside sphincter. So we have two sphincters, the internal and the external sphincter, which maintain the competency of the rectum and prevent stool leakage. But as you can see, the outside sphincter is torn. It's not there up here. It comes from here, goes back till here, but it's missing in the front. And that is called partial separation of the external sphincter. Once we've done all these tests, whether it is a defecating bowel study or stool diaries or urinary tests, then let's talk about the management. So by now you have probably undergone most of the tests, if not a couple of tests are still outstanding. But once these tests are all completed, then we will discuss what is to be done. So essentially and generally speaking, the management of prolapse is three parts. One is expectant, second is pessary, and third is surgical procedure, where I've called a fourth category of avoiding a hysterectomy. Expectant meaning to do nothing but just to observe. So this is usually in a patient who comes in and has a small prolapse that is really not protruding out of the vaginal opening, and she's not really bothered by this. She does not have any complaints about this, and it's just an incidental finding that someone may have noticed and referred the patient to us. In that case, we may just choose to do either a 6-monthly or a yearly follow-up to see if it's worsening, or in some patients who may not want this to advance, we may recommend pelvic floor therapy. So what it involves is a muscle stimulation with physical therapy and electrical stimulation of the pelvic muscles, which is done in the office. The session takes about half an hour and takes about 4 to 6 weeks on a weekly basis to do it. But what it does is it strengthens the pelvic muscles, and there is really nothing required before or after, and there is no pain or discomfort, and classically indicated in patients with mild prolapse, and especially after a surgical correction to improve the muscle strength of the pelvic floor muscles. The second thing I mentioned was PESSARY. PESSARY essentially is a device which is put inside the vagina to sort of lift the prolapse in place. It does not classically correct the prolapse, but it sort of hides the prolapse inside. It's an office procedure. It takes a few minutes to decide the type and the size of the pessary, and it's ideal in patients who cannot be taken for surgery. For example, someone had a recent cardiac stent and is on a blood thinner, and the blood thinner cannot be discontinued, then we would be forced to use a pessary. It reverses the ill effects of the long-term prolapse and prepares the vagina for surgery as it pushes the vagina in. And remember the slide where I showed those ulcers of the vagina? Once the vagina goes back inside, the ulcers will heal, the vagina will essentially become normal inside, and once that happens, the surgical correction also will be more successful. The pessary also has disadvantages. The biggest disadvantage is it needs frequent visits for life. I mean, that's the thing. It's not just, okay, I can go to the doctor's office for 2 to 3 years and then I'm done. No, you have to come to the office all the time unless you manage the pessary on your own. In our practice and in our experience, most women cannot manage the pessary on their own, and they come into the office for changing it, and we usually do it every 2 to 3 months, unless of course there's a problem. So the problem is what? If there is discomfort and she's feeling some pain because the pessary could have moved, there is vaginal discharge, which is typical with the pessaries, spotting and bleeding. So this is because the pessary is inside and it could rub against the vaginal walls on a consistent basis and cause erosion and therefore bleeding. Sexual function also may be hampered, especially with some types of pessaries, and one may have to remove the pessary for having intercourse, which is not easy to do. And also sometimes the pessary may not stay in because it may keep sliding out or keep falling out. Finally, the pessary could also result in urinary leakage. The pain that is associated with the pessary could be because it's either too tight or it's dislodged in the vagina. So you put it properly, but then it shifts in the vagina, and that can cause pain. And sometimes the pain is so much that the patient has to go to the emergency room to get the pessary removed. The vaginal discharge is usually because of an irritation of a foreign body in the vagina, and the vagina reacts to that. And some patients will say that it's like a fishy odor and a continuous foul smelling discharge coming out from the vagina. Vaginal bleeding, as I mentioned, is usually because of the erosions. Now, the biggest problem is that if there is a pessary which causes this erosion and the pessary then cuts through the vagina into a neighboring organ, now that could be a disaster, because then you have a problem with bowel perforation, and that may result in a colostomy. So that's one of the worst things that can happen with the pessary if it cuts through the vagina and goes into the bladder or the bowel. Now, usually that happens if a pessary has been neglected. Sometimes the pessary is pressing on the urethra and there's difficulty emptying, and as I mentioned, urinary leakage, and of course it's not staying in. So bottom line with the pessary is that it can be tried by everyone, but it's ideally suited for patients who are high risk for surgery, and pessaries are not free of complications. Now that's very important to remember. People think that, oh yeah, it's an office procedure, we'll just put it in. But overall, the risks still do exist. In fact, I've seen more erosions from the pessary than from vaginal surgery that I perform. The long-term pessary management becomes a challenge, especially as the woman gets older. Then how long can she come to the office on her own? Does she need assistance to be brought in? If she does not come in, then how do we manage the pessary? So all those things become challenging issues. And the worst thing that we can have is a pessary that has been neglected and it just stays in there, and that can truly cause trauma to the vagina. So it is a temporary fix. If the pessary is left out at any time, whether it's in 2 years or in 10 years, the prolapse is going to come back. So it's just essentially hiding it. It's not fixing it or correcting it. When you talk about surgery, you have different types. We have this native tissue repair, the mesh augmentation surgery, hysterectomy. If not, what we do now is we do not do a hysterectomy. We do what's called uterine preservation. So we keep the uterus, and that procedure is called HYSTEROPEXY. And finally, vaginal closure procedure. So these are the different procedures. Let's talk about one at a time. Native tissue surgery is where we're using the patient's own fascia tissue. Most cases would need a hysterectomy, especially if the uterus is also prolapsing. And if it's a large prolapse, there's a almost 75% chance that the prolapse will come back again. So really, if you look at it from the large prolapse standpoint, you know that the tissues have essentially given up and weakened and torn and sometimes inexistent. So then to just use very, very weak tissue and put them together really makes no sense, because the recurrence of prolapse is very high, and the last thing a patient wants is to go back for surgery again. So it's coming back to the previous slide. So it's ideally the native tissue surgery is suited for women who have a mild prolapse, somewhat bothersome to them. The fascial supports are okay essentially, and we can put them together. In patients that we typically see with large prolapses, especially when it is coming outside the vagina significantly, then native tissue surgery may not do justice, especially if we want to preserve the uterus and not take it out. The mesh augmented surgery is attached, where the mesh attaches to the strong ligaments and the muscles of the pelvis. So essentially the mesh takes over where the fascia used to be. Now the fascia is essentially gone and torn, so now we put the mesh and attach it to the ligaments and the muscles of the pelvis. In the past, the fascia was doing that, where it was attached to the ligaments and the muscles of the pelvis. So it's usually when you have a large prolapse, such as especially a front wall prolapse or a cystocele, and in patients who have recurrent prolapse or who are at very high risk of recurrent prolapse, such as those with large prolapse and have very high risk factors such as smoking, significant coughing, or significant weight, then they would be better served with mesh augmentation procedure. Now, when we come to HYSTEROPEXY, which is uterine support procedure, it is almost impossible to do this with just using patient's tissue. You have to use something synthetic to hold it in place. And what our results, and I'll show them to you in a few minutes, is that mesh surgery works great for that. So as you can see, this is again the normal pelvic organ. So let me give an orientation. This is the front where you have the pubic bone. The bladder is this, which is partly opened. This is where the uterus is, and the upper part has been removed. And this is the rectum. So as you can see from this picture here, that you see this green thing here. Now that is the fascia on which the bladder is resting. These ligaments are the ligaments that are holding the uterus in place. So if this fascia has completely weakened, the bladder is going to fall out. If the ligaments have weakened, the uterus is going to fall out. So what we then do is we place a mesh that attaches to those ligaments and the muscles and replaces the fascia, which has essentially gone. So this is the mesh that we use. It's called the RECTAL mesh. It's a very lightweight, permanent polypropylene mesh. Has a large pore to prevent infection. It's a single filament of polypropylene which is woven into a mesh. And this polypropylene or proline is an inert thread and has been widely used in surgery. And most recent studies also have shown that this is well studied, at the same time well accepted material in the body, and the risk of cancer has never been found with this polypropylene material. After we put the vaginal mesh surgery, so essentially once all the organs have been replaced, we put a little bit of a vaginal support device like this to just sort of hold the vagina in place like a mold, so that if the patient strains immediately after surgery, well, everything is just so freshly placed, it should not just break down. So it braces our surgery for a few weeks, and then in about a few weeks we take this thing out, and there is essentially no discomfort or pain to remove it. So what we call our procedure at my practice is NINOS, N-I-N-O-S. It's a no incision natural orifice surgery. Why no incision? Because we do not open the abdomen, nor we go laparoscopically or with the robot from above. We do not need to do that. We can go through the natural orifice, which is the vagina itself, and operate from inside the vagina. And this is therefore done entirely from inside the vagina, and there are no incisions, nothing to show on the outside. Potential risk of any surgery, and any and all that I mentioned to you right now, whether it is using the patient's tissue or doing something else, are bleeding that could happen, injury to the neighboring organs such as the bladder or the bowel, infection that could happen of the incision or like bladder infection, urinary leakage, difficulty emptying the bladder, pain, postoperative pain or pelvic pain or pain during intercourse, and finally failure of the procedure. The only thing which is specific for using the mesh is exposure of the mesh. That means if you can see the mesh, and that obviously makes sense. If you don't use the mesh, you will not get exposure of the mesh. If you use the mesh, then you would get exposure of the mesh, or you could potentially. But again, please note that that is not a complication of the mesh itself. Let me come back to the previous slide. That is actually a problem of healing, and we'll talk about that in a few seconds. The temporary voiding dysfunction, that means sometimes what happens is that patients may have a catheter for about a couple of days or may go home with a catheter. And that's because, during surgery, the patients get a lot of IV fluids. They have edema and swelling and inflammation around the bladder. We put local anesthesia, so their bladder is numbed a little bit. So the bladder says, you know what, I need some rest. And that's what we do. We give it some rest. And when they come back to the office, they can all empty their bladder very well. So again, if you have to have a catheter, remember, it's a temporary thing. I have yet to have a patient who was not able to empty her bladder within a few days of the procedure. Sometimes if they don't want to put the Foley catheter in, especially if they're avoiding okay but not completely, we may teach them how to catheterize in the hospital before they're discharged home. So then they don't even have to come to the office. They can control it on their own. But then this again is a very low risk, and I'll show you the incidence in a few seconds. Pain during intercourse, also called dyspareunia, it's actually for different reasons. One is because the vagina essentially feels different. Now you have to remember that a prolapsed vagina has been very lax, very loose, very open, and now you're creating a proper vagina where it is therefore obviously tighter and what's called a new normal. What I basically say, it's like a pair of new shoes. Now yeah, your old tattered shoes felt great because they were very loose, but they were tattered and you can't keep wearing them. So now you buy a pair of new shoes and they feel snug, and that's what you may initially feel. That's a typical thing that most patients feel, and then they get used to it. So the key thing is regular intercourse and expected management is all that is required. Sometimes there's little scarring, but that could happen with any surgery. And the only discomfort that the partner may feel is if there's a mesh exposure, which again, in our hands and using the new Restorel mesh is very, very infrequent. In some patients, to help with this, especially in postmenopausal women, estrogen and vaginal dilator would help. Rarely, because of a tight perineum, we may have to release it, and rarely would we have to release a tight mesh. I have yet to release a tight mesh because of pain during intercourse. What one has to remember is that this is not specific to mesh. Pain with intercourse can happen with any surgery done in the vagina, because any surgery in the vagina will naturally cause scar tissue formation and can potentially affect some of the nerves and can cause pain. But again, the pain during intercourse is very, very unlikely. In fact, most studies, and especially our study, has shown that sexual function in fact improves because now the patient doesn't have a bulge and she feels like having intercourse because there is nothing falling out. Before, she was having intercourse much infrequently. So one reason why she may be having discomfort is because she's actually having intercourse now, as opposed to the fact that she was not even having intercourse before when the vagina was falling out. So the bottom line is complications which are encountered with prolapse surgery are not unique to mesh. Mesh exposure or erosions which happen in cases where the mesh is used, but then again, it's not due to the problem with the mesh itself. So it's not that the Restorel mesh caused a problem. It is mainly because it happened due to the healing process. And in some women, if the vagina doesn't heal well, whether it's a blood collection at the back or it's poor healing tissue due to smoking or other factors, such as a previously failed procedure and there is scar tissue already, then it may not heal well and the vagina may open up a little bit and cause the mesh exposure. The technology has improved so much now, and our surgical technique has advanced also, that we rarely see a mesh exposure in the vagina. And erosions in the urethra or the bladder or the rectum, we have not had, and I'll show you our data. So then what is all this talk about? This information on all this fear factor on vaginal mesh surgery, and it's bad, and we see all these ads on TV. So what's all this, is it just noise? Well, lawyers have lumped all the complications together, whether it's sling and mesh for prolapse. Now, these multi-district litigations, as they call, they usually go after the deep pockets of the companies. They're not really going after the doctors because, it's more about a financial gain also. So the information which is given is exaggerated. Mesh is an excellent tool that if unavailable, prolapse and incontinence management would be hampered. However, not all that is said on TV is untrue. Mesh surgery is very complex and should only be done by experienced surgeons. So this is even what the FDA is saying. And this is what our medical societies are saying, that this is not something that anybody can just pick up. Just because I'm an OBGYN or I am a urologist, I can just do this. Or even if I'm a urogynecologist, it should be done by someone who does this frequently, knows the anatomy, knows why you're doing it. So if it is done, on the other hand, for the wrong reasons in a poorly selected patient and by an inexperienced surgeon, then yes, complications could happen. So mesh is indicated only in certain patients. It's not to be performed in all patients, only in certain patients, and it is very important to discuss with your physician. So when you come to talk to me and when you read the information, we will tell you why would it be indicated in your case. So this is the key thing. What I would encourage you to do when you come to see me or wherever, if you're watching this as part of our media information, you could say you have to ask this question. What is your experience, doctor, with using the mesh? Why would you recommend mesh in my case? What is your complication rate? What would happen if mesh did not work in my case? And would you be able to take care of me if there are any complications that arise from the surgery? So this is exactly what the FDA advisory states, and this is what we've given you in our book in a question-answer format with my answers to those questions. And now let me tell you as to those questions. Doctor, what is your experience using the mesh? So I have been using mesh almost since 2004, and I've had very good results, and we've published our data ever since then. So our first publication was on a mesh called the PROLIFE plus M mesh, and our success rate was 94%. We had no intraoperative injury to the bladder, bowel, or any other viscera. We had no blood transfusions in these patients, no hematomas, no mesh erosions into the bladder or the rectum. We had only 2% cases of mesh exposure in the vagina, which were managed very simply, and only 6% of patients experienced some pain with intercourse, as opposed to what is published in the literature, where almost 15 to 35% of patients have pain with intercourse. This is again with or without mesh. We had no patients with difficulty emptying their bladder. So remember I told you about the need to go home with catheter. So, that's a transient thing. Nobody had ongoing difficulty emptying in this study. Then after that, we moved on to the next generation of mesh called the EXAIR mesh, and our success was 93%. Again, no intraoperative injuries, no blood transfusions, no hematomas, no mesh erosions, no difficulty emptying, and mesh exposure was only 4%, and pain with intercourse we had none. And I mentioned the studies show 15 to 35%, and we had no patient with pain with intercourse. Then our next study was on vaginal mesh hysteropexy, which is where we were supporting the uterus and not taking the uterus out. So this is something that now we have done more and more of, and essentially patented how to do this particular procedure. So typically when the uterus is falling out, the tendency is to take it out and remove it. And it makes sort of sense. The vagina is coming out, the uterus is falling out, you are postmenopausal, you don't need the uterus, you finished having babies, it's falling out, take it out. But that doesn't really make sense, because the uterus is not the problem. Uterus is actually the victim. So why would you be going after the victim? The problem is the ligaments. So what we do is we support the uterus through making new ligaments using the mesh arms, and that holds the uterus in place. So we did this study where we had 77 subjects who had a stage 3 out of 4 or stage 4 out of 4. If you remember the picture I showed you where the uterus was coming out completely, that would be a stage 4 out of 4 prolapse. So in these patients with very large prolapses, our success rate was 91% with keeping the uterus. So the published studies now, remember this, published studies on native tissue repairs. So if they try to use the patient's own tissue to support a large uterine prolapse, they would have had 75% failure rate. 75%. Ours was only 9%. So you can see we can preserve the uterus, and there are many, many advantages of doing that. So what is our experience? Like one of those questions that you were supposed to ask me. The total number of meshes done at our center is over 1,000 cases. The success rate is over 95%. Risk of complications is less than 5%. So overall, extremely positive when it is done for the right reasons. So what are the things that we look into when we come with this decision-making analysis? So you look at patient factors, prolapse factors, and the surgeon experience. So when you look at the patient factors, it is the severity of prolapse. How much is it coming out? What is the degree of bother for the patient? Is it the first time, or is it a previous surgery that has failed and therefore it's called recurrent? What are the patient's comorbidities? Is she obese? Is she a diabetic? Does she have compromised tissues because she's a steroid user? Compromised tissues because she's a smoker? Compromised tissues because she has gone through menopause? What are her desires? Does she plan on having sexual function? Does she not want to have sexual function? What about the surgeon? What is our experience? And I just shared that with you. And then what sometimes when we go and say, okay, now let's see what we find at surgery. When we find at surgery and we open up the vagina and we realize, oh my God, there is just no tissue there. And that is where we may see tissue weakness and we may have to modify the procedure. Finally, are we doing a hysterectomy or are we keeping the uterus? Bottom line for prolapse management is this. It all depends upon how much is this bothering you and how it affects your quality of life. That's the key. It's not how much it affects me or your husband or your friend or anybody else. It's how much does it affect you. Finally, important to understand balancing this level of bother against the true evidence-based information that I just shared with you about the risk-benefit profile. So you cannot go with imaginary risks or imaginary benefits. You have to go with what is really the facts out there. And again, the facts are different. The facts at our center are very different from facts which someone else might put up. So all I can share with you is our results and what we have found in following our patients. What you will notice and what we may have already told you is that once we do a procedure on you, you will be following up with us for a period of time. And that is what we do. We gather our data so we can then analyze our results and if need be, just improve or share our results with our patients. So, it's a safe and effective when it is done for the right patient, for the right indication, and by an experienced surgeon and for the correct reason. So remember, this is the key statement. So every woman is different. So you cannot compare, oh, she had this done, it was great for her. Jane had it done and it was horrible. Everything went wrong. So I don't want to have it done. No, it all depends upon each individual case. Who was the surgeon? What was the situation? So all those three factors are important. The patient factor, Jane may have a totally different problem as opposed to Mary. Number two is the surgeon. This could be a highly experienced surgeon who did one patient, whereas a very inexperienced surgeon who did another patient. And third is even the material also is important. So, but the patient factor, the surgeon factor, and also about the material factor. Postoperatively, these do's and don'ts after surgery are all in your prolapse booklet that we've given you. So please read them. It goes about everything that you may want to know. Activities, showering, can I have intercourse? When do I go to my activities? When do I go back to work? It's all mentioned in there. Bottom line, prolapse is a very common problem. Large prolapses can cause complications, and these complications could be lethal, and you may not even realize they're happening. Treatment options have dramatically improved now. Even if surgery is done, it is done completely from the vagina, no belly incision. We have even now perfected a technique for postoperative pain control or discomfort control. And recovery is very speedy. In a couple of hours after the procedure, you're essentially walking, you're eating, you're moving, and you are just staying in the hospital overnight, just to be there really, because there's not a whole lot that happens at night, and next day, you're home. So what are the next steps for you? If you have not undergone the tests that I mentioned in this discourse, then you will go through those tests. You should read the medical literature. Not only hear what I said, but also read what I've given you. And at the end of that medical literature, there are a few questions that I've put, that's just to help you, stimulate your memory and say, okay, what are the real points that I need to focus on? And it'll help you focus on, especially it's questions like, hey, why am I going to have this surgery? Or what's information about the mesh and according to medical societies and just things like that. So please follow up at a consultation to discuss the best management, which is based upon your desires and your medical conditions. So that's important. So follow up at consultations at a consultation. So when we'll talk to each other and we'll go over, okay, in your case, how do we tailor make to your particular situation? This is how prolapse was managed in the past. Woman was held upside down, tied up, and gravity was used against it so the prolapse would go back inside to reduce it. Well, we've come a long, long way since that time. Nowadays, prolapse can be taken care of in almost every patient to the point that the surgical correction is so successful, so low risk of complication, and patients could potentially be going home the same day after the surgery. The discomfort and the pain is so minimal, especially since the procedure is done entirely from the vagina. Healing is much faster, recovery is much speedier, and it's over. Once it's done, you have a very, very high chance that there will be no recurrence of prolapse. So forget this. We do not need to do any of this nonsense, and let us do the way it should be done based upon evidence and facts and publications, something that I've already shared with you. So I look forward to going about this and discussing with you at the consultation visit and then coming up with the final plan.